Hello everyone, myself Dr. Malini, consultant biochemist from Sundara Medical Foundation, Annanagar, Chennai, located in India. Thank you for joining with us today. Today I'm going to walk you through a real case, a diagnostic challenge where a child with clinical signs suggestive of Duchenne's muscular dystrophy had falsely low creatine kinase CK values. Let's explore what went wrong, why it happened, and how can we prevent such issues in the future. We all know that the lab tests are central to clinical diagnosis, but lab tests may be unexpectedly misleading at times, especially in cases involving very high analyte concentrations. One such marker is creatine kinase, a critical enzyme marker used to assess muscle damage. Now, unlike simple assays that rely on fixed concentration measurements, CK is measured using enzyme kinetics. This means we are looking at how enzyme behaves over time. It's actually a dynamic process, and understanding that process is very key to avoid misinterpretations. Enzyme reactions usually involves lag phase, linear and plateau phase. And this case, what I'm going to present is a kinetic pitfall happened in high CK value. We had a 5-year-old male child who presented with muscle weakness. The child had both proximal and distal muscle weakness, weakness of orbicularis oculi, and developmental delay. The child also showed positive Gover sign and exaggerated lumbar lordosis. So there was a strong suspicion of muscular dystrophy. The treating clinician ordered serum creatinine kinase as the first line lab investigation. However, the lab results was unexpectedly low, that it was less than 10 international units per liter. As the lab values were discordant with the clinical picture he suspected, the pediatrician referred the boy to pediatric neurologist, and subsequently after a week pediatric neurologist sent another sample for CK estimation. So now this time, by using delta correlation, the laboratory recognized the same test has been performed a week earlier and now being repeated again. Upon reviewing the electronic medical record, we are able to identify a likely clinical suspicion of muscular dystrophy, which prompted us to do dilution of the sample and reanalyze. So we performed initially 1:1 dilution and then 1:5, 10 and 20, and we achieved a final creatine kinase value of 27,340. The case raised several questions in our mind. Why the CK value was falsely low in undiluted sample? How did enzyme kinetics influence this reaction curve? Is it similar to hook effect? And finally, what process control we must apply to prevent such issues in the future? These questions are not only relevant for this case, but for any enzyme kinetic assays. To understand our case better, it is essential to understand the enzyme kinetics. So usually enzyme kinetics progress or increase in a linear fashion. As the reaction progresses, it eventually reaches a plateau phase. There are 3 phases in the assay. Lag phase, where there is no product formation but there is a conformational change in the enzyme. And then linear phase, where there is steady formation of product and it reaches plateau phase gradually, where no more increase in the rate of reaction happens. That is, addition of substrate will not increase the rate of reaction. Usually in all chemistry analyzer, the reaction is monitored by measuring absorbance at 2 specific time points. The first reading is taken right after the lag phase, that is just before the linear phase, and this is referred to as initial rate. And the second reading is taken at any predetermined time point that is set by the manufacturer. The first reading is called as initial rate and the second reading is taken as final rate. So the difference between these 2 readings, that is final rate and initial rate, is what we often call it as delta absorbance or FOD, that is final optical density. And this is what the analyzer uses to calculate the enzyme activity also. So this kinetic approach is generally reliable, but it fails under certain conditions like extreme high concentration samples. So this figure illustrates what we just discussed. After adding R1 and R2 to the sample, the analyzer calculates the difference between initial and the final rates that was shown in the blue dots. Now on the right, that is figure 1b, this is what would have happened in our high CK value also. So the enzyme activity, that is creatine kinase activity, was so high in the sample that it used up all the substrate available in the reagent instantly, and the reaction entered plateau phase too early, even before the analyzer could take the initial reading. So the analyzer sees no difference between the final and the initial reading because both fall in the flat portion of the curve. So the delta absorbance was almost zero. So what happened in our case is because of excess CK in undiluted serum, it consumed all the substrate even before the measurement window opened. Reaction curve reached plateau phase so early, and there was no change in absorbance between the initial and the final reading, resulting in falsely low CK value. And the reaction curve took a rectangular hyperbola instead of a linear curve that usually happens in an enzyme kinetics. So the true value was revealed only after serial dilution, which normalized the substrate to enzyme ratio. This phenomena resembles very similar to hook effect, which we technically come across in immunoassays. But this is not hook effect, but it is hook-like effect. The difference between hook effect and hook-like effect is, in classic hook effect, which we see in hormone analyzer, the analyte or the hormone usually saturates both the capture and the detection antibodies, and so leading to falsely low values. But in our case, that is in enzyme kinetics, high CK enzyme caused rapid substrate depletion even before the measurement window opens, resulting in no change in the delta absorbance, leading to falsely low results. So we refer to this as hook-like effect in enzyme kinetics, and because the basic difference between hook and hook-like effect is, though the phenomena is similar, the reason behind or the cause behind the phenomena is different. In hook effect, it's due to saturation of antibodies, that is capture and detection antibodies by the analyte, whereas in hook-like effect, the cause is because of substrate depletion in the lag phase. But just like hook effect, the solution is the same. We have to dilute the sample, because dilution brings the enzyme and substrate ratio back to optimal range, allowing them to behave in a proper manner and also give accurate results. To conclude, this case highlights an important pitfall in enzyme assays, especially when dealing with very high analyte concentrations like creatine kinase. A falsely low CK result occurred not due to instrument error, it's not due to reagent failure, but due to enzyme kinetic limitation. The enzyme in the sample consumed the substrate rapidly even before the analyzer could record the reaction properly. And most importantly, we as lab professionals must correlate lab results with clinical context always. And when lab results seems to be discordant with the patient presentation, we must also dig deeper, look at the raw data of the analyzer, and understand the enzyme kinetics or what went wrong. We must also know when to dilute the sample if in case an enzyme kinetic abnormality is suspected. It is also important to reinforce and re-educate our lab staff and professionals about the assay and the analyzer principle and possible abnormal behaviors as well. To sum up, a 5-year-old boy clinically suspected to have Duchenne's muscular dystrophy showed unexpectedly low CK results. CK value was reported to be less than 10 on 2 occasions. Lab correlated with clinical notes and performed serial dilution. The final CK value was high. So the reason for falsely low CK value was substrate depletion in the lag phase of enzyme kinetics, and the issue was resolved by understanding the absorbance data and reaction curve better. In a broader clinical picture, first, never rely solely on the numerical values. Always interpret lab results in context to the clinical picture. Number 2, Recognize assay interferences and kinetic abnormalities better. Number 3, it is always vital to understand how analyzer works, measures enzyme activity, and when to perform dilution. And finally, we must also encourage a culture where abnormal results must not be just repeated, but to be investigated by thorough analysis. This approach ensures patients receive right diagnosis and right care. Thank you for your patient listening, and I'm open to questions now.